Hi, welcome to the course. My name is Fuad, and this video series will help you understand your reading material, assessment, and health professionals education. Now I'll point out to you in this series what's important, what's not so important. So let's go right to it.
Continue with the last discussion, which is the threats to validity. As usual, we will discuss threats to the validity for all kinds of assessment methods, right? So similar here, we will discuss the threats to the validity of performance tests. This is in page 151, and there's a very nice summary in table 9.1. So please have a look at the summary, and please have a look at especially the methods to, or the strategies to reduce or remove the threats. That's the important part that we need to know. Okay, but let's have a look at the components. As usual, we will discuss our approach this discussion by looking at the two main groups of threats, right? If you remember, CU and CIV. So we look at CU first, the construct under representation, right? So construct under representation means that we are not sampling enough, or if we are sampling enough, we are not sampling throughout the domain of competency. Okay, so as illustrated in very nicely illustrated, I would say, in the book, you might not be sampling enough. This circle is the domain or of your construct. You might not be sampling enough, or in another way, your sample is enough, but you are just sampling one area of the domain or your area of interest. Okay, so the key is systematic sampling. And if you remember our general discussion on this, when we talk about sampling, this is the area of content validity, and therefore what's important is the blueprint. All right, and so if you go through the chapter, this area, what is generally given as a guide is the 3 C's: the content, the competencies, and the characteristics. Okay, let's have a look at each. Regarding the content, of course, you would want to cover all content. For example, you would want to cover acute myocardial infarction. You would want to cover, let's say this is for an internal medicine posting. Okay, covering for an internal medicine posting, or you are the course coordinator for internal medicine posting. So in terms of content, you would like to cover the areas such as acute myocardial infarction, infections, cancers or neoplasms, and the list goes on. So this would be based on your outcomes. Okay, right. And what about competencies? Of course, I think let's say this is a year 4 posting, so you would want to look at their history taking. You would like to look at their physical examination, and you would like to have a look at their management skills and communication skills, and the list goes on. Okay, so this is separate. And of course, another C that we often forget is the characteristics, which means the patient characteristics. So we want to make sure that they are able to handle males and females of all age groups, and so on and so forth. Okay, often you will find, especially here in our situation, the patients in the OSCEs tend to be males, middle age, because those are the people that is easier for us to find. and easier for us to train. Usually we grab or we source out from our friends and staff in support staff, our friends of support staff and things like that. So we rarely find standardized patients who are, let's say, pensioners or old women and things like that. So make sure, or we try our best to make sure that we sample all kinds of patients' characteristics. So that's the 3 C's as mentioned in the book. Okay, and there's a nice sample blueprint given. You can see that in box 9.5, page 153. All right, it shows you the possible way of making a blueprint. Okay, and how do we approach in terms of content and competencies? You might have your own content competencies based on your school and your learning outcomes, but there are frameworks that we can refer to, and these frameworks are given in box 9.6, which is page 154. So have a look at these, and a few interesting things that you can find in, especially in the table as well as in the discussion. One question that often crops up, and you will be asked this later on, is how many cases are enough? How many cases are enough for an OSCE? And if you look at the table, the summary of the discussion, it says there 8 to 10. Okay, at least 8 to 10. Okay, and how long can a station be? It varies, all right? Maybe a very simple or very localized or very focusing on, let's say, examination of the knee or something which is focused, then that it can take about 5 minutes. But if it is much more holistic, history taking, generating a management plan and things like that, you can go up to 10 minutes per station. But generally it is said that you need 4 to 8 hours of testing time to get a reliable results. Okay, 4 to 8 hours. Let's take 4 hours, 10 minutes per station. Then you in 1 hour you have 6 stations, and 2 hours 12 stations. So to get 4 hours, 24 stations. Now how do we get 24 stations or 4 hours of testing time in one go? That would not be very possible, but if you can split the OSCE into OSCE 1 or OSCE 2, or maybe you can combine results from OSCE 1 and in semester 1, another OSCE from semester 2, perhaps we can reach 4 or even more hours of testing time. Another issue that is covered in this discussion under the representation is that rarely students will have the chance to see all cases in that is outlined in their learning outcomes or in their logbooks. All right, and because it, to a certain extent, it depends on the chance of meeting the required cases in the wards, because in wards, as you know, it depends on the patient characteristics, which happens to be admitted and things like that. Okay, so an OSCE will be one way of you to identify the curricular gaps. All right, which patients are difficult for students to see. So if students complain that they are not able to answer certain types of patients, then it's one way for you to identify any gaps that you have in your posting. Okay, we'll continue with the second part of the discussion, which is looking at construct irrelevant variance. Okay, and this is nicely summarized again in table 9.1. All right. So basically, when what do we mean as a revision? What do we mean by construct irrelevant variance? Now, what is variance? Variance is the difference in the marks between one candidate and the other. Okay, and what are the sources of these differences between one candidate and another? Basically, it can be the person, the item, the case, from the standardized patients, and so on and so forth. Okay, so let's look at the person first. The person meaning the candidate, and the differences can be that one candidate has more competency, more of the construct than the other candidate. So this one we are not too worried. This is the one which we want to see actually. So we don't have to do anything about it. No remedy needed as written in the table. Okay, so the other source is the item. Item here in OSCE means the station. Okay, so it can be from the checklist or the rating scale that is used by the raters in each of the stations. So different raters will have different understandings of the item or the checklist, so they do not understand how to use the checklist or the rating scales equally or similarly from one rater to other. Okay, and of course things to overcome this include carefully wording the items, training, and so on and so forth. Okay, so just to give us an idea, please look at table 9.1. Now, the next thing is the case, what we call as the case-specific variance, meaning individual students find some cases more challenging than others. Okay, performance is variable across cases within an exam. So again, of course, you a patient with a neurological problem, for example, will be much more difficult, at least to me, than someone who has then a station asking you to take history about chest pain. Okay, so here an obvious strategy would be to increase the sampling, because we cannot reduce the difficulty if it is inbuilt in the case. The next source of variance is the standardized patients. Standardized patients can portray cases incorrectly, or different standardized patients vary in how they portray the case. So of course, the strategy would include training and quality assurance methods. The next source of variance are the raters themselves, where, as we have discussed previously, raters will have errors inbuilt into them. Being a human rater, they will have biases such as leniency, severity, central tendency, and things and so on and so forth. So again, the strategy, as you might imagine, would be training. Another source of variance that we might miss is that performance in students might differ depending on the occasions. So you do it on a weekend, you do it on the first day of the week, you do it on the last day of the week. It might affect students' performance. Okay, especially if you repeat the same OSCE in different dates or in different locations for that matter. Okay, so if the OSCE is done on just one day in one location, then perhaps this is negligible, because all students is sitting in the same hall. Okay. However, within the same hall, you must be aware of all the areas. Usually, OSCEs takes place in a big hall, so some parts of the hall might have faulty air conditioners, for example. But then, if it affects one station, then all the students in that particular station will be uncomfortable. So in a way, it cancels out that thing. But however, it suggests here, as you can see in the table, occasion specific. It suggests that we control the environmental factors and test it on several different occasions. Okay, so if that thing is relevant in your situation, please think about this. Okay, the final thought is that often you will get asked, or you might be thinking of this question: do we need 2 raters per station? Will 2 raters be better than 1 rater? Okay, the answer to that is that the case specificity, which is the variance due to cases and the interaction between cases and persons, is usually the greatest source of variance in performance tests, and it is a much greater source of error than differences between raters. You can find this in page 155. Okay, it means that the difference in cases is a much more important source of error, and therefore you look at the sampling is a more better strategy compared with looking at raters and trying to reduce the variance from raters by increasing. So it says there, having more stations with 1 rater is better than having less stations with 2 raters. Okay, so that is why we go for more stations even though they have only 1 rater per station. So that's in a nutshell the discussion about the threats to validity in performance examination, especially in OSCEs.